Thank you. So participants, today I'm going to share with you my journey from practice to policy making, and I'm going to explain to you the role of pharmacists in making the paradigm shift in the healthcare system. As far as I can guess, we have 124 participants online at the moment, and I hope most of them are aspirant hospital pharmacists or currently working as hospital or retail community pharmacists, so mostly practitioners. So my message to all the practitioners or future practitioners who are listening to this presentation right now, that this is for you, because you are going to shape the future of the pharmacy profession in Pakistan, and not only pharmacy profession, but also the healthcare system. So some of you will be attaining this role of having a macro view of the health system and delivering a bigger role of pharmacists towards the healthcare system, that is policy making. So it is to you, you can identify which line, which area you can choose to get into this policy making venture and play your role, because we really need that, because we are developing health system. So we need people from the practice to contribute to policy making so that the system grooms in a positive direction. So I'll start my presentation from here onwards. Okay, so Huma has already given my introduction, and you can find me on the LinkedIn. You can find me on Twitter. Twitter, my handle is Huma Rasheed 4, and you can find me on ResearchGate as well. So best is this, that all the aspirant researchers or people who are in practice and want to expand their knowledge and get into areas like policy making, they should get into interactive forums like Twitter or LinkedIn, where they can find global leaders and organizations with whom they can interact. And this is something that our professionals should do, that is interact with the outside world and gain inspirations and ideas and do collaborations, so that they do not get tied up in what they see and what they are given in the local setting. So they have to expand your knowledge and experience beyond that. So this is my recommendation. So please follow each other, follow global leaders on Twitter and LinkedIn, so that your vision gets expanded and you get broader exposures. That's the new way of learning things. So as I told you, I'll be sharing my journey from transforming from a practicing pharmacist into a policymaker or a researcher who does participate in policy making. So I started my journey as a pharmacist from the Children's Hospital and the Institute of Child Health, Lahore, in May '99. And this was a pioneering project in public sector for modernization of pharmacy services. When we started off in Children's Hospital, there were hardly any pharmacists over there, and there were hardly any role of pharmacists in the healthcare delivery system, except that the medicines were procured and distributed into the different wards and dispensaries or OPD of the hospital. So small steps taken at this nascent hospital led to bigger goals or higher goals, which ultimately impacted not only our profession and its grooming, but also the healthcare system in Pakistan. A little detail step by step that I will share with you. In May '99, when I joined this institute, we were like a team of 2 pharmacists who were started with this project of modernization of pharmacy services in 6 autonomous hospitals of Punjab. So Children's Hospital was one of the hospitals which voluntarily participated in this project. And then the project director then, Professor Dr. Saeed Ul-Haq, was very enthusiastic that the Children's Hospital gets into this venture and develops systems which are similar to Shaukat Khanum and Aga Khan Hospital. So I was a pioneer internee from Shaukat Khanum. So I had a training of what was supposed to be done at the Institute for the Development of Services. So my first intervention into the system was to deliver 2 tasks. Number 1, thing which was noticed was this, that there was no proper prescription and administration record system in the hospital. So there was a lot of focus definitely on the documentation of the inventory and tracing each and every tablet and injection, where is it going, and nothing is wasted. But it was on the floor, the standard of prescription documentation and administration documentation was very ambiguous, and no clear picture could be drawn when you try to study the file retrospectively, or you try to get the history for a long-term patient. So first I attempted to correct these, and we also received a training from a team in UK in this respect, and Punjab government supported that. And we implemented the strategy which they gave to us, that was using a single sheet, which is used by pharmacist, doctor, and the prescriber to record the prescription, monitor prescription for its errors, and also for the administration record. So in this way, we were avoiding transcription, which is the major source of error in the healthcare system. My healthcare team, unlike the experience of many others who share that the pharmacists were not allowed or welcome to intervene and change the system, my healthcare team always supported my interventions, because I always made them these interventions very easy and friendly to them. So when we are avoiding transcriptions in the health system, we are not only avoiding errors, but we also reducing the time which is wasted in doing these transcriptions. So nobody likes to, copy the prescriptions, and doing that you make errors, and it's such a hectic thing. And we already have a lot of burden in the healthcare system and shortages of staff. So this was the first intervention. So you please, the people who are listening to me, or the practitioners who have just joined the healthcare system in Pakistan, because what I see in healthcare system in Pakistan, we as a pharmacist are just not entering there as a healthcare professional. We are the leaders of our own department. We are given the task of establishing the pharmacy services. So every pharmacist, a graduate pharmacist who enters a hospital facility, and he is the only pharmacist, or they are like team of 2 or 3 pharmacists, the first pharmacist the hospital has ever seen. So they are not just needed to be the pharmacists, they are supposed to be the leaders as well, the planners as well. So for you, this is a good strategy, that you pick up from the things which develop teamwork, which makes clinics identify you as a friend, as a person who supports, who coordinates, and who is there to solve their problems, and who does not create problems, but is there to solve the problems. The second step, which was very important in paving the way that we will be able to deliver what we want to deliver in the system. When a pharmacist reaches the healthcare system, he has a lot to give. Every student who has graduated from a pharmacy college or school, has studied so many subjects, has a lot to give to the healthcare system. He identifies so many problems, but are you going to put all the things on the table immediately, all together in one go? No, you have to make a strategy, a plan how to implement those things. So those things which involve less conflict and a broader policy level role, and corrects many things in one go, are the best things to do in the first hand. So pharmacy and therapeutic committee formulation and its proper functioning is one such step. It is one basic essential needs. It's the beginning of the it marks the beginning of the pharmacy services, a proper formal beginning of the pharmacy services in any hospital. It's just not the committee which sits together to see what is going to be purchased in the hospital. That's a different story. That's a purchase committee kind of a thing. It has to do with the decision making. What are the clinics going to use, and how are the clinics going to use these medicines? What is going to be the protocol? So it has to be grounded on some evidence. some documentation, some research, some international and national guidelines. So earlier to your introduction into the system, because most of the pharmacists, as I told you, are the first pharmacist of that facility, which the facility has ever seen. So you are going to introduce to them what is the concept of essential medicine, what is formulary, how it is grounded with the standard treatment guidelines, and how we can use the resources like British National Formulary or electronic medicine compendium from UK, and use the local data for drug availability like Pharmapedia or PharmaGuide for checking the price and availability data, and collectively know what we can deliver to the system, what is available, what is not available, and along with the clinical guidelines which are there to support the rationale for inclusion or deletion of such things. So it's like the first experience that all the clinical decision makers are sitting on the table doing a teamwork to decide how medicines are going to be used in the hospital. So you have, marked your presence on the floor, being there on the floor by developing proper prescription and administration record system. So you daily go there into the clinic, sit with them, work with them, help them out, making better prescriptions, and not only writing and record, but also making the reviews and identifying the drug interactions. So this is the next step. So they see you as part of the team. Then you take a time out every week or every fortnightly. You go into the pharmacy and therapeutic committee and you present this task that we in the hospital are going to make our first formulary. And for this, we are going to review each and every type of medicine at therapeutic class which are going to be used in the hospital. So you're going to interact with all kind of specialists who are there in your hospital. So this builds the basic ground for your further development of services in the hospital. Then at the third step, what are you doing is there when you're going to the wards and you're saying that I'm there to help out this record keeping system, and we are developing a good and proper and standardized record keeping system. Along with it, you tell them that they are these standard books.
Ma'am, your voice is not audible. Are you there? Okay, done.
Okay, so sorry, I forgot to unmute. Okay, so can anyone update me where we had left? So I can see that the connection had dropped. Okay. Okay, can anyone share please on the chat? Okay, so so we were like talking about that we have entered into the clinics with this query, with this agenda that we are going to help them out in making a proper prescription administration record. And then with the bigger consultants or professors, we are running a pharmacy and therapeutic committee meeting, which is running as a weekly meeting or a fortnightly meeting so that we can develop a hospital formulary. The third thing we are there that we are spending 90% of our time in the clinics. Say that you are there in the clinics with the team. Your day begins in the clinic with the team and you leave for home from the clinics, so that they view you as part of the team, not as a person who comes there as a guest and whenever feel likes makes an intervention, gives a suggestion or helps you out. No, you have to be there and develop an ownership that their problems are your problems and you are going to be there to solve all these problems. Anything which is regarding medicine is your domain and you're going to help them out and you're not going to leave them with a question mark and unattended. So in this way, you start attending clinical ward rounds and you start doing the prescription reviews and you identify medication related problems and you start entering into the stream which is called participation in the clinical decision making. So this develops your credibility and you have given the information which is like minimizing their problems. And I tell you that the subjects you study in pharmacy, there are many subjects, and some of the subjects are also shared by the pharmacists, and there are some subjects that which are also shared by the clinicians. They also study pharmacology and therapeutics, okay? They also study biochemistry and physiology and so and so, but there are some subjects which are your specialty. For instance, my master's is in pharmaceutics, and my PhD, you can say, also is in pharmaceutics and amalgamation of pharmaceutics and the policy, which is can be said that pharmacy practice. So when you apply the information which you get from your pharmaceutics class or which you get from the pharmaceutical chemistry class, this really helps them out because this chunk of information was absent from there. How the medicine is going to be stored, how it's going to be prepared, and after preparation, there is a change in the medicine expiry. When you changed it from the solid powder, you entered the solvent into it, now it's more prone to degradation and its life has changed. Its life is now not the one which is written on the bottle. It is now changed to some reconstitutional expiry, which is to be allotted according to the data which the books tell you, or sometimes it's also there with the medicine information leaflet, which is inside the or direction circular, which is inside the carton. So the clinicians and the nurses and the team in the clinics before you were working there, they are not used to using those information. They can read the English of it, okay, of course. And they can also understand what does English mean, but they cannot understand the sensitivity of it, you know. So some students, some participants wrote that we are the first year pharmacy students, okay. So, but you have studied Arrhenius equation, and you know, many of the clinicians or nurses have never studied Arrhenius equation in the whole of their life. So they don't know that 10-degree rise in the temperature is going to degrade the product twice many rate, and how the expiry is calculated, the shelf life is calculated. So they are not sensitive about this information that the change of solvent is going to degrade or change the life of the product. So you provide this information. I give you one example. There was a diazepam infusion going on for the patient, and the clinicians were having this problem that the fits are controlled for some time, but after some time they start reappearing. So they cannot get that sometimes the fits are being controlled by the infusion and sometimes they are not controlled by the infusion. So I checked it out and I told them that the duration for which the infusion were being prepared was longer than the recommended duration in which the product is stable in infusion forms. form. Like for instance, it was 4 hours and they were preparing the infusion for 8 hours. So in the rest of the 8 hours, the infusion was not at all stable. And this stability is far more dangerous than expired product. If the product is going to be expired in like 5 years, this expiry is going, this claim is going to be finished off or not going to be remaining there over there. This claim of your essay, the content is correct up to the 95% or 98%, that is going to be going off the claim in 4 hours. So the degradation has become so fast. The 5-year degradation is now taking place in 4 hours. So the using it after 4 hours delay is a tremendous damage to the patient in terms of like toxic progress being produced and in terms of loss of efficacy. So when you give such kind of information and you be there, you develop your credibility, then what happens that they approach you even before writing a new medication. So you are in a perfect position to start drug information service. But when you start drug information service, you try to document those drug information service, because it takes a lot of time to handle a query properly. And mostly the queries, they repeat themselves as well. So if you have done your homework and you have documented it, then it helps you out in the next time when the query comes, you can deliver the same homework again without investing much of the time. Remember, when we were starting the service, we were like 2 people in the whole hospital, okay? And that's mostly the case you're going to see. When you're going to be there in the hospital for the first time, at the first entries of the hospitals, you'll be 1 or 2 or 3. So you have to see how you're going to save your time. The other thing is this, when you document that which queries are coming in, then you can get to know, okay, this problem or this query is being repeated so many times. Why don't we make a protocol and conduct a training of it? And we paste those protocols on which we have done the training in all of the wards, so that the issue does not remain there. The query is resolved for everyone. So this, these few little things, right in the first appointment of a fresh graduate. In 99, I was a fresh graduate, like many of you. This changed the culture of the hospital and their view towards these new alien entrants, people who call themselves pharmacists. So what is the end product of it? That you developed a healthy team concept with the other members of the healthcare team. And unless you step in, you get this way into developing this first milestone, that is your team concept established, your ownership as a team established, you cannot go into the further complex areas of intervention and service establishment. Here, I would also like to mention that during this process, we also conducted trainings of, I would always use the word we. It's never I. It's always a team. So you're the pharmacist who is working with you, your pharmacy support staff, your nurses, and the administration who has allowed you to do all of these things freehand. Remember, Children's Hospital was one hospital whose project director has willingly participated in the project for establishment of modern pharmacy services. So there was a political willingness from the top, which helped the services to be established. So we train the healthcare professions on infection prevention and control, proper handling and preparation of pharmaceuticals, especially sterile medicines and devices, how disinfectants should be prepared, the choices of disinfection, what is asepsis and what is aseptic handling, how unit dose dispensing system can be helpful. So in this way, by baby steps, we started developing our role in the hospital. So this was like in the first few months till August 99, we were able to achieve all these tasks. So let's move to what happens afterwards. What happened afterwards, that in September, we decided that the patients coming to emergency should be delivered unit dose dispensing system. Before that, we have already established our services in ICUs. That was only located in ICUs, and frequent rounds to emergency when needed. But the whole hospital knew by that time that whenever they have a problem regarding medicine or a query, they are these two girls who are supposed to be contacted, and they will help you out, and they will not sit unless your queries are solved. So in the next big step was this, that we made pharmacists available at all times in the hospital. We had a third hiring in the hospital. We were now 3 pharmacists, and we volunteered ourselves, and we convinced our administration that we will start 24 hours unit dose dispensing system to the emergency ward, in which every prescription, and I'm talking about September 99, every prescription in the emergency will be reviewed for dosing, for rationality, for age or DIs, and will be prepared according to its protocol, the way it should be prepared. It will be disposed of according to the protocol, that according to the reconstitutional expiry, and will be delivered to the ward in labeled syringes. So this reconstitution services was maintained by the pharmacy staff. And at that time, the Punjab did not have free 100% emergency supply system. But we could not run this program without having a free 100% emergency supply system. So we developed a donation bank which supported the lapses in the stocks, and we could then provide the 100% coverage also, and deliver our unit dose dispensing system. Simultaneously, because it was a pediatric hospital, we were receiving a lot of poisoning cases. So we arranged some antidotes, and we developed an antidote bank. Whenever the antidotes were used out of it, we used to refill it. And so it also went into, adding one more service or one more component of the pharmacy systems, so grooming it further. The other thing which we identified while staying, all these things, remember, all these things we were able to do because we were available and present on the patient bedside. Had we been far away in the offices, doing some paperwork and purchases, or that is important thing as well. We were able to do all these stuffs clinically on the floor because someone was doing the purchasing stuff back there and making the medicines available. So it's not like I'm disregarding that, but for establishment of pharmacy services, you have to be available on the floor, on the bedside. So we also identified that there is a need of compounding service. So we had the cases of some rare disorders which needed some apparently very simple preparations, but those preparations were not marketed formulations. So we studied what is extemporaneous preparation, how we can do, how the world does it, what are the other people doing in the rest of the country. So we initiated our initial compounding services at that time. So we also devised a system for emergency trolley management, their expiry checking, and then also identified this because we were continuously working in the emergency and the ICUs. We identified that the emergency trolley medicines were there, like adrenaline is there, but adrenaline is not going to work, will be available, is not going to be available unless water for injection is also there, unless an appropriate syringe is also there to make the dilution, unless the guys over there know how to dilute it. And when the emergency is practically happening, patient is in front of you, that is not the time to train people and tell them, do this dilution, or not this solvent, but this solvent. So we identified the role of protocol development. So the protocols should be developed beforehand. Clinical teams should be trained beforehand. All queries in this regard should be dealt with beforehand, so that when the patient comes and we have an emergency conditions, we have all the things in place and we know what to do, and there is no confusion, so that patient is given the best services in a safe way and an efficacious way. Of course, it's logically a correct thing to do. So that's why our clinical team felt supported, and they were like more attached to us, and they were now kind of advocating our services. And at the end of this whole story, what is the outcome? We were now working as an integral part of the clinical care team. There was no concept that the emergency ward is going to be run without our emergency pharmacist, and that the emergency pharmacist is not present in the round, that we do not get the unit doses prepared. And this lifted a lot of burden from our healthcare partners, nurses, and diverted their time towards nursing care. And it also took off from them something which is very, very, very redundant in the system, which is killing the time of healthcare professionals. That is, they do this expense and inventory management of the medicines coming in and coming out in the emergency. And this all by taking the time out from attending their patients. So unit dose dispensing. So see, whenever we are introducing the service, we are also helping them out, and we are making their work easier. And we are, in return, we also telling them that we have to go by some protocols. We have to go by some evidence. If the data suggests we are going to prepare the medicine this way, we are going to do this way, and not the way in which we do not have the data or the data do not suggest. So there is a condition. Okay, again, I don't know where we stopped. Can you hear me now?
Yes, ma'am, your voice is audible.
Okay, so can you guide where did the connection stop, or it was just a few seconds ago? Yes, after the protocol. So should I go to the last slide? Okay. Protocols. Okay. So we developed protocols so that the emergencies are managed in an effective manner. And so see, this way we are transferring our pharmacy knowledge to the clinical teams, and they are giving us more and more credibility and ownership. Yes, please.
Ma'am, your video is not shared, ma'am. Please share your video of the presentation, ma'am.
The slide share is not there. Okay.
Oh, yes, ma'am. The slide share is not shared.
Let's see. Okay, so we developed protocols for the emergency trolley system, and at the end of whole of these 4 or 5 months, almost a year since we have joined, we are now an integral part of the clinical care team. And this is all because we had been persistent and we have been responsible, and this brought credibility for our services and our professional roles, and developed ownership in the system for these new people called pharmacists. So then 2003, I took a break of 1 year and then came back to Children's Hospital in 2003. And this time I came back with a promise that I will start the total parenteral nutrition service. Earlier to that, I was always giving only the advice on the total parenteral nutrition. And because we didn't have any infrastructure, so it was very difficult for us to get into the real preparation of TPNs. But in 2003, we managed to get some laminar flow hood access and started doing the total parenteral nutrition. And our clientele was preterm and low birth weight infants mostly. So we also have for TPN malnourished cancer patients and burn patients and many surgical patients. So either it was mostly neonatology or it was mostly surgical patients which were in the dire need of TPN. So TPN in neonatology is not like TPN in adults, because neonate is born very small, and within a few days or weeks he has to gain so much of the weight. So unless he is not getting proper nutrition, he's not going to grow. So he's not like an adult who has already grown and only has to maintain their body weight. So they have to grow and increase their body weight, and because they are in hospital means they are sick and they have a big stress of their disease on that and fighting the disease. So that they need energy and they need nutrient supply to fight their disease as well. So absence of the nutritive needs of the body for a long term is an indication for starting a TPN. And the target is to deliver a well-calculated, properly calculated, sterile, particle-free nutrition designed to cater the individual need of that particular patient, which varies from day to day on the basis of the lab profile and the current disease status of the patient. So I stress this well-calculated, I stress this sterile, I stress this particulate-free nutrition. Why? Because this was the reason I was compelled, despite we had very less staff, despite we had very less resources, it was very hard for me that I know how to prepare it. And because if you do not prepare it in the pharmacy, it will be prepared in the ward. It's not that if not, you are not going to be preparing it in the pharmacy, they are not going to give it. They have to give something. So they are going to do it in their own way, in which the calculations will be compromised, in which the sterility is definitely going to be compromised, in which there is no clue of particulate contamination. So what are you doing with the patient is not any benefit. It's just a package of big harm, and that is being given from your hospital, and you have provided all the granulas and IV lines and amino acid solutions and fat emulsion and dextrose solution and electrolytes, and in the ward they went in to get being prepared into a TPN which was non-sterile, which was probably containing particulate matter, even the glass particles as well. And the calculations were not poor because they were not trained to do that. So we had to intervene. So most of the people assume that in pharmacy services, TPN is like something which is, if it's there, that's good. If it's not there, the system runs, it's okay. But for neonatology, it's not okay. It cannot be done like that. And many other many other conditions also it might be so, but in neonatology, it becomes a very severe hang-up. Aseptic preparation in ward is not possible. And so you get into the high rates of septicemia and your patients go into infections. And it's also for the low birth weight, preterm fighting patient, where you putting them into septicemia is such a practice which could be said that it's against the code of healthcare practitioners, that no harm should be from our side, from the health practitioner side. There were a lot of miscalculated and catabolic prescriptions. So what we did, we studied the documents, how the neonatology prescriptions are managed, the clinicians who worked earlier in the neonatology sections abroad, they shared their protocols which they used abroad, and we collectively made an indigenous protocol, and then which had a monitoring side and preparation side and build up, how we are going to build up, how we're going to wean off, how we're going to communicate with the clinicians. So Then we started the services of TPN in 2003 in pediatric settings in Children's Hospital, which was probably for the first time ever in any public sector hospital. And we also had to, during this activity, we have to adjust what for the concomitant drugs. Means if you are doing TPN, total parental nutrition, means you are taking responsibility of all the nutrients which are going to go into the body of the patient, all the sodium, all the potassium, you are putting by hand. He's not going to get it from any other source, proteins, fats, even water. So you need to know what else patient is getting from any other source, and what is like any other medicine he is taking. Medicine is also being prepared in some kind of solvent or sometimes in an infusion form. So you have to accommodate for the add-ons and losses from that side as well. So again, you are more ingrained, more deep down into the clinical settings, working coherently and coordinating day in, day out with your clinical team. So this actually results into developing a system. Now, many of you are like working, alhamdulillah, in Shifa International or going to Shop Khanam or Aga Khan or even in Children's. There is Taba, there is Dow, there is Liaquat National, so many institutions who have developed system. So do not assume that when they started, it was as simple as that. When it started, it was way tougher. And for many of the pharmacy people, pharmacy young graduates, this is going to be the scenario, because there's whole of Pakistan, so many health facilities who are waiting for you to join. So you have to go there, not waiting that someone had established over there the systems. No, you will be there establishing the systems for them, and do not shy away from that. And you will be able to do it, because information is so easily accessible now. We are in the age of technology, and you are listening to this lecture for the story of something happened in 1999. Okay, so now let's pause and see how this practice story relates to the birth of a policy scientist or a policy maker or a policy researcher. Along with all of this activity that you are doing, you are in a small amount of time, you are developing so many systems, you are intervening at so many places. You have to remember that you need to document everything. And you have to analyze every step and make solutions for the problems and document the problems. And once you have done that, you have to disseminate this information. So if you properly do all this process, you slowly become a policy scientist. How? You know, all these things are like pharmacy services things. They were not research things. They were not apparently policy things. So how they turn into policy making? So I tell you how the same experiences and services which we have like in the past, like 15 minutes have gone. Let me check the time. Okay, we have just 10 minutes left from the end of the session. Anyway, so let me browse you through. You know the essential drug concept, which is the basis of the formulary development, that medicine which should be there at all times and in appropriate forms and in a way that the community or the hospital can afford. And with this, our formulary-based drug utilization system, we came across that many drugs are not available in Pakistan. And they are kind of orphan. This term orphan drugs, though, is a different term, and it is the term which is for the medicines which are used to treat diseases fewer than 200,000 patients, and there are very few. There are numbered diseases which are like that, for which the patients are in such a small number. So whereas essential medicines cater to the need of the 90% of the population. So mostly in Western world, it's the orphan medicines which are talked about, that the people cannot access it, they are not available. But in our country, in Pakistan at that time, even now for many cases, essential medicines are also not present. So we documented all this in the form of research. This was in 2005. We published it. We presented it in the conferences. We presented in the in-house conferences, in the conferences which were in the front of ministry, in the policy-making meetings in the ministry, that please acknowledge this fact that these medicines are necessary, endorsed by WHO, even endorsed by the National Essential Medicine List, but are not available in Pakistan. So we have to work for them and for availability collectively as a government, as pharmaceutical industry, and as practitioners. If it's not available, then we have to find ways for the alternatives or so. But we cannot leave the things hanging in between. So this thing ultimately became the source of inspiration for my further research when I got into the position of doing research. Other thing was this, the things which were needed for the rare diseases and needed compounding. So compounding we do for the things which are not marketable or which are to be prepared extemporaneously as per patient need, and most of the orphan drugs also need these services. So these are also for the off-label drugs, for the drugs which are available in the solid dosage form, but not available in the oral liquid dosage forms, or are available in the IV, but not in the oral dosage form for given on the OPD basis. But thing is that these complex diseases or rare diseases mostly have very simple solutions. So these formulations are mostly not very difficult ones, but somebody has to make it and make it in a proper way. So there are resources which you deal with. These are some glimpses from actual premises from where these things were happening and the kind of services which we started, some numbers. And then in 2008, I got a chance of, as a founding director, that I established a pharmacy institute in a veterinary and animal sciences university. And along with it, I also started the first bioequivalent study center in Pakistan and was responsible for its quality assurance segment. And I initiated practice and policy research and became in charge of the hospital and clinical pharmacy course, which for the master's class. And from there on, my time came to do active pharmaceutical policy research, which ultimately got published in Q1 journals. And I trained many postgraduate researchers in doing training on these areas. So as you know that I've been the member of the think tank for the medicines policy of Pakistan. I've also been part of the research project doing research on the evaluation of the education and regulation of pharmacy profession in Pakistan, and also for the classification of essential antibiotics according to AWARE, which is access, watch, and reserve groups classification for antibiotics, for the way the medicines should be restricted and used in the society. So this whole of these thing comes under the various section of medicines policy. So as per WHO, whenever you work upon appropriate medicines to be available consistently in the healthcare system, you're working on medicines policy. When you're making sure medicines are being prescribed and dispensed appropriately, this is the part of medicines policy. When you're working that the medicines become affordable and become in the reach of the patients and the organizations who purchase them, then you are working on the medicines policy. So because Pakistan is a low middle income country, and many of the low middle income countries, the government do not provide all of the medicine. Many people have to rely on the private resources. They go to private facilities for their medicines, and they spend out of pocket. Means who is the buyer of the medicine? Patient is the main buyer of the medicine, not the organization. When the organization become the buyer of the medicines, the decision-making process changes. Which organization can become the buyer of the medicines? The insurance companies can become the buyer of the medicines. And then they will talk about, like medicines should be used rationally so that our bills should be lowered. Our expenses should be lowered. But when people are the payers of the medicines, and people do not have any voice because they do not represent any organization, So there are so many things regarding the access issues that medicine are not available, but who cares? Because there is no representative organization who is representing the main buyer of the medicine. The government is not the main buyer. The insurance company is not the main buyer. The main buyer is fragmented in the whole of the population and giving and paying out of the pocket. And there is there is no unanimous voice of that population because they are not organization. So that actually becomes the major reason why the pharmacy services get stuck at many points in the healthcare system in developing countries. And Pakistan is also one of them. So this is one major reason. And unless this breaks through, it's difficult to implement pharmacy services and solve our problems which are related to pharmaceutical policy in our region, in our country. So my research, when I came back from Germany after doing my PhD, the first student who was given to me for the research, they did the same research on a more comprehensive manner for scanning the whole essential medicine list for which medicines are not available in Pakistan. And it was published in PLOS ONE, a very reputable journal. And this is the condition which we saw, that the items in yellow and purple and orange are the ones which are not available or not registered in the country, and the ones which are in green are registered in the country. So you can see in case of antimicrobials, the one which is in the front, the smaller graph, the one which is in the back is for the rest of the 19 categories which we analyze. But the interesting point is this, that when you do research, it tells you how big the problem is, what is the shape of the problem, and also gives the answer how we can solve that problem. So when we analyzed it, we found that 26% of the medicine were not registered in Pakistan. Though registration, if the medicine is not registered in Pakistan, you cannot sell it. Though somebody can prescribe it, but you cannot go and buy it from the market because it is not there as a registered medicine. So it would probably not be there. Or if it be there, maybe it's from some illegal source, which is an illegal act. Or maybe you have to specially purchase by special permissions from abroad. So it's quite a hectic job. So 26% is a big number. It's almost 1/4, more than 1/4. So when we go into looking in this 26%, we also find that 51% has no solution as such at the moment. 21% are available with some modification, slight variation in the specifications. Like, if the list has 200 milligrams per 5 ml suspension, the market has 125 milligram per 5 ml suspension. This is just an example. So, with slight variation, you can get access to it. And the one in purple is a very interesting area. This is about the substances which are not registered in Pakistan, mostly age-appropriate preparations, but can be compounded in the in-house, like Shifa has the in-house, very good, large, big facility of in-house compounding. So these medicines have a potential that they can be compounded in the in-house pharmacies, and we need not to wait for the manufacturers to make them and then make them available in the market. And maybe their clientele and their requirement is not that high, or maybe it's not among the priorities of the manufacturers, or maybe it's just still never been discussed with them. This could also be the case. But unless you identify the problem, so see how a practitioner during his or her career faced a problem, and then when they got time and resources, worked upon it and researched it out, ultimately gave a guideline to policymakers to that if you want to make available the essential medicines in the country, this is the way you have to move forward. So you enter into as an important component of the policymaking business. So similarly, we worked on anti-cancers, we work on antivirals, essential antivirals. pediatric anti-cancers and essential antivirals. And our work was appreciated and presented in the 2023 winter meeting in the Netherlands at the WHO Collaborating Center for Pharmaceutical Policy and Regulation. So these are the results of one of the studies in which we studied where the availability of essential medicines at various facilities in Pakistan. So you can see it's a heat map. And of course, the red shows that it's not available. We searched out the medicines in the 10 facilities, public, private facilities. And you can see that the medicines in the access group of antibiotic, which were supposed to be present, they're supposed to be accessible in the best way. They had all the colors in red. So as you move towards the next access group, this is the picture. And this is the watch group. This is not the access group. And this is, you can see a lot of green over here. So this is also a watch group. And this is a reserve group. There's a lot of green and just red for one of the product, one or two of the products, okay? So see, the things which were supposed to be accessible are not accessible, which were supposed to be restricted, the antibiotic which were supposed to be restricted to ensure that antimicrobial resistance is not growing so fast, they are more accessible. So unless we do the data, we do the research, this is not going to be identified, and this is not going to be solved, and this is not going to change the policy then. So with the experience, you know which research question to pick, which will inform the policy so that the system grows in a positive direction. So here is another example. This study was done by my undergrad students. And I say that we don't need just competent people. We need empathetic people, which are sensitive to the needs of its population. So we need health activists and leaders who are also competent pharmacists. So only competence is not going to answer your problems. You have to be passionate about it. You have to be leaders and knowing how you are going to execute what you want to achieve. And you have to be empathetic. You need to have empathy so that you can realize the importance of the needs of your patients and your clinical teams. So this was published in a very high impact factor, again, 6.464, and was done by third-year pharmacy students and was on a very simple concept that do the university students know about oral liquid medicine administration tools and what is their opinion about the household spoon. So very interesting data we got from there, just looking at the types of spoons and asking them questions. So historically, if you see, like the journey which I've told you, how a practicing pharmacist became a policymaker and started contributing what should be the pharmaceutical policy of Pakistan, which areas should be given importance and how they should be dealt with. Our profession has historically gone from, a very basic count and pour practice system. The pharmacists in 1950s were not allowed to discuss the therapeutic effects or the composition of the prescription with the patient. This is APHA Code of Ethics in 1950s. So this was our profession in 1950s. And 1960s, pharmacy therapeutic committees were being made. And in 1976, the statement changed. It was said the ultimate goal of the services of the pharmacy must be safe use of drugs by the public. In this context, the mainstream function of pharmacy is clinical in nature, one that may be identified accurately as drug use control. And now, in the current age, we practice pharmaceutical care, that is the responsible provision of the drug therapy for the purpose of achieving definite outcome that improves the patient's quality of life. So see, our profession is dynamically improving and progressing in a way that it has transited from just a technical supply of some items to a cognitive-based profession where pharmacist is involved in the clinical decision making. And the further future of it is the emerging role of pharmacists in public health. The role of pharmacists in changing the national health indicators of the country. What are the national health indicators? Infant mortality, neonatal mortality, maternal mortality. So when the next step is this, that pharmacists work in a way that it impacts the health system, that its bigger healthcare indicators get corrected. And yes, you can do that because it's the pharmacy from where the breast milk alternative are being sold out. So it's the pharmacy from where iron supplements and folic acids is sold out. So if the pharmacy staff is going to train, it's the pharmacy from where zinc and ORS are sold out. So it's the pharmacy where people come and tell their simple problems, like they got diarrhea, they got headache, and they are the ones who guide them firsthand before they go into any other healthcare professional. So unless they know what to say and what not to say, what is in the public health interest and what is not in the public health interest, if the child has a diarrhea, should the mother feed be continued or the mother feed should be stopped? And if they come to buy the formula and say we dilute it because we cannot afford it, and you don't even know what to say to tell them that please stick on to mother feed and do not use infant formula unless it is indicated, unless the mother feed is not there, because it is compromising the health of our whole nation and increasing the infant mortality and under 5 mortality of our population. So you have a big role sitting in the community pharmacies, placing your public health impact because you are in direct communication without any appointment with the patient. So this is the healthcare system you can see with a Pandora box of more than like 60,000, even nobody knows what is the exact number of medicines registered in Pakistan. And both doctor and nurse actually want to have the best knowledge how they're going to prescribe, how they're going to administer. And there is a poor patient in between who doesn't know anything and depends upon these healthcare professionals for everything. So pharmacist is the one who provides knowledge in linking all these channels and delivering the best services to the patient. So this whole ambit in which it tries to deliver these services is called pharmacy practice. The professional skills of the pharmacist needed to ensure the optimal use of the medicines in the society. And it is an inevitable transaction in the healthcare system. Unless the patient gets the medicine, he's not going to be cured. Yes, there are certain ways in which the disease can be prevented, and there are certain diseases in which the medicine is not needed, and you can get from non-pharmacological methods also. But again, that's also an information and has to be there with you so that you can provide it. So medicines are important major health expenditures also in the healthcare system. And as I told you, out-of-pocket medicines, OOP, out-of-pocket medicines, is a major issue in the developing healthcare system because people are the buyer of the medicine. They are the main source of funding. So inappropriate use of medicines lead to major clinical and financial consequences, and you need to use more medicines because your conditions got worse. But who is suffering here? The same patient who is doing out-of-pocket medicines. Has the institution suffered and their budget gone up because of bad practices? The institution would have said, somebody stop it. But because it's the patient, so their voice is not heard. So there is a triad of processes: education, the way we are educated, then we practice, and then we do research. And then research actually helps these things to be upgraded to a higher level so that the things are not remaining bad. So legal frameworks and policies are established. We develop products, ingredients, or services, and this development of products, ingredients, or services has to be evidence-based. You need to give what is needed, the service or the product, not what is not needed and what is already so many times there. So what does it involve? When we talk about medicines, it involves prescriber, it involves pharmacists. You need to know this because when you do pharmacy practice research, you are going to interact with all these areas, people and areas. Of course, nurses are there. Of course, the patient is there. So this is the main character scenario. Then there is manufacturer also, a big corporate body who manufactures the medicine, distributes, markets, sells. And then there's a belief system of the patient. There is an economic function of the country, of the people, of the corporate sector. There is media and the digital aids and information technology working also, and which is continuously informing or disinforming the public or the society. So then there are managerial and organizational behaviors and functions which allow you to develop a service or pose a hindrance in developing a service. So there's a legal framework and there are systems and policies. And then is very interesting thing, that is digitization and IT infrastructure. That is big friend of yours, and your future depends upon digitizing and IT infrastructure. You can do tremendous amount of work with less effort, but organized effort through digitization and IT infrastructure. So what we as health practitioner who wants to participate in the policy change have to take some segment of this interactive bubble and work on it and try to make that segment an interactive forum, medicine and economic function, or medicine's relation to media or digital aids, or medicine with relation to healthcare care system policies, and make it better in a dynamic fashion. So we are here, we need to optimize the use of medicine in the society, identify the problem, design a solution, implement the solution, evaluate what we have done, and then revise and improve. And the cycle goes on, and document this. And this is research, and this is helping the policy move forward. So there are certain resources, there are certain examples that people have done it. People have used pharmacy services for smoking cessation. People have used pharmacy service, improved pharmacy services for repeat dispensing and improve the way in which the medicines are being used in the society. And there is a lot of work which has been done on the new medicine services so that the medicines are used in a safer way in the society. Very important fact. Folic acid awareness. After this session ends up, you can go and Google about folic acid deficiency and the role of pharmacist in it. And there is a paper by Major and et al., which I'll be giving you references at the end, that this is a pharmacy team who has worked on folic acid awareness, that all the women in the reproductive age, all the girls in the reproductive age should receive folic acid every day in the dose of 400 microgram, so that the children do not bear neural tube defects or spina bifida. So this is a very simple intervention, and folic acid is available in Pakistan in a very cheap form, and mostly in a as part of supplement as a multi-ingredient, and pharmacists can help which multi-ingredient formulation has appropriate dosing of folic acid, and that the people can use, women can use, or girls can use, so that they do not face stillbirths, and they do not face missed abortions, and they do not face delivering a baby who is having spina bifida and gets disabled because of the surgery or because of the spina bifida. So do read about it. So there is increasing role of pharmacists in monitoring chronic diseases, which are also called NCDs, and collaborative disease management projects and home medication review projects. And there are plenty of examples over here which are delivering in this field. There's evolution of the professional role, which can be the documents, and the journey of this evolution can be seen from this reference from UK and South Africa. And there is a whole field of research which is called health services research, which does this research on which person in the health system delivers which kind of services and can be helpful in making the change. And many of these health services research have targeted have been done on pharmacists, and pharmacist has gained new roles, and these roles are defended by the research. The slide is not moving. Let me see. Okay. So this is the future of the pharmacy practice research. So if you want to go into the policy making and do pharmacy practice and policy research, you have to be informed that you are going to be dealing with the IT literate population of the world now. And you have to be aware of the cultural and social disparities which are in the healthcare system and in the societies. And the organizational behaviors also are impediment or facilitator of any change you want to bring in. So you need to understand them. So medicine optimization and the pharmacovigilance things, they need a lot of pharmacoepidemiology kind of research. And pharmacy as business and information system, you need to study business administration, sociology, and economics. So see, I have listed out, and this is from a paper which is published, Future Research Areas in Pharmacy Practice, that if you want to groom your services and you want to understand your profession better, keeping the future in mind, you have to attend these, you have to understand these subjects or these areas, or interact with them, or have them as your collaborators so that you can understand your problem better. So pharmacy living in their own balloon cannot solve all of the problems. To solve the pharmaceutical problems, pharmaceutical policy problems, they need to interact with economists, with social scientists, with people from information technology, with anthropologists, epidemiologists, political scientists, administrators, so that new solutions could be developed. So these are certain issues which are reported in the pharmacy practice research, which is done from the developing world. And mostly it's the skill and training. Very less work is being done. There is no funding or no setting of research priorities. There is a mindset that only the research is the one in which new drug is discovered, and that is the research. So this mindset has to be broken if more people has to come into, doing research in the areas which inform the policy. So, or checking of the prescription, or checking if the standard treatment guideline is being complied or not, or just checking into if we make the counseling services mandatory, what difference it will bring into the lives of people. So this is not going to use a sophisticated HPLC or NMR or any other instrument. So would it not be called a research then? Definitely it's a research, and it's a very important research that saves life, and that helps us use the national resources in a better way. So mindset needs to be changed. Your view of what you view as science needs to be changed, so that you can do quality research with confidence. And there has to be political willingness in doing that by your organizations, by educational organizations, by funding agencies. So as a conclusion, more involvement of practicing pharmacists in policy research will help to develop a better healthcare system and better pharmacy systems in Pakistan. Making use of information technology to aid evidence synthesis is the way to move forward. And we need to understand pharmacy practice research methodologies, because it's a new area. These research methodologies are not similar to doing titrations and doing HPLC analysis. They are different research skills, and they need a different skill set which need to be worked out, which need to be learned. Allow slow and credible research. Do slow, credible, doable, honest research. Do not try to aim to be big and complex. Do simple things, doable things in an honest manner, and that will gain a place in the evidence, and you can see will be published in a bigger journal, like our paper on a teaspoon done by a third-year students got published in Frontiers, which is a leading journal with the 6.46 impact. And with this way, if we keep on doing work, we'll be able to mobilize national level funding. And the state need to own that it needs to catalyze the process that helps the practitioner turn into policymaker and do research and inform the policy in an evidence-based manner. Here are some of the materials. If some of you have gained interest into my presentation and want to go into the roles of being a policymaker or a policy researcher in future, I recommend this one. If you want to read just one paper, read this article. It's a what do you call? It's a landmark document in health systems, if in this century, I must say, up till now. Essential Medicines for Universal Coverage by Lancet Commission on Essential Medicine. It's written by the team led by Veronica Wirtz and Professor Hans Hoggershill, has Andy Gray in it, and Miriam Bigdali, and Margaret Evan. So these are the global leaders. These are pharmacists and they are global leaders, and they have given this document which covers every aspect of pharmaceutical policy and how we go about it to create a better future for the world, both for the developing countries and for the developed countries. So if there is one document which you want to study to understand what is, and most of these people who are written here, Veronica Ritz, for instance, have worked practically in hospitals, have been on floors, and practitioners like you, and now they are global leaders. So study this paper, study this article from Lancet, and this will be a big resource for you. So next is my own chapter, which is titled Evidence-Based Pharmacy Practice Research in Low and Middle Income Countries, Issues, Challenges, and Synthesis. It's published in Professor Zahiuddin Babar's Encyclopedia of Pharmacy Practice and Clinical Pharmacy. I have co-authored it with Professor Izham and Professor Zahiuddin Babar Saab. And if you want to dig into what kind of research work should be done in low and middle income countries or countries like Pakistan, and how you face the problems which we normally come across in this regard, what could be the pitfalls which could be avoided. So study this chapter, please. If you need this chapter, you can write to me and I can send you the PDF because it's not open access. And there are certain documents from the WHO, and among them, I would like you to please insist and learn about aware classification of antibiotics. Aware classification of antibiotics. Google it, study it from the WHO website. So this is the key resource which I'm giving out, so that some of you who have the interest and the potential and the opportunity can turn into policy researchers. We need it. We badly need it. We don't need 2-3 people in the whole country to be working on it. We need many people to understand it, and most of them or many of them to even work upon it. So many people should understand what is it all about, and then a certain proportion would be able to be getting the opportunity or interest to work upon it. So please do study this paper by Veronica Ritz, Essential Medicines for Universal Health Coverage, published in Lancet in 2017. And here are certain other references, certain books for the pharmacy practice research method. Well, there's one which is by Professor Zahiuddin Babar, and the first chapter of this book is written by Christina Bond. And it's a marvelous chapter for an overview on pharmacy practice research methods. And it's a good way to begin your pharmacy practice research learning. So there are certain references which are being quoted in the whole of the presentation. And this is all about it. Thanks and good luck.
Thank you so much, ma'am, for an amazing lecture. Indeed, it has added value to our knowledge books. Can we have some questions, ma'am, please?
Yeah, sure, please.
Okay, some of them have questioned about it. Is it that easy to make a good team? You have graduated in 1999 and you had a team and you all worked for betterment this soon in 1999.
Yeah. So the most important thing is this, that, I have been repeatedly saying in my slides as well, that is the team, and that team, building team with the other healthcare professional, the healthcare team concept, and the building team in your own pharmacy department. So you ask, had it been easy? No, it's not been easy, but it's been very exciting. I tell you very interesting thing about it. Most of my support staff, like dispensers, they would say, madam jab bhi muh kholti hai na, hamara kaam hi badha deti hai. Means all the way around. You must have seen, I've been taking out work from the nurse's pocket and putting it in the basket of the pharmacist or the pharmacy department. So of course there was a retaliation from the pharmacy department side as well, that now they do not have to do that work, and why we have to do that work, and nobody has done it earlier, so why we have to do it. But slowly, when they realize that how much benefit it gives to the patient and how much wastage and misuse it can stop, they become part of it. For instance, with very less resources, I started TPN and all these services and aseptic dispensing for unidose dispensing for certain medications. I used to train all of my pharmacy staff, pharmacists, which I used to have. In the later phase, we had more pharmacists, but because, in a big tertiary care hospitals, there are some people who are going to work in the purchase. There would be some people who will be working in the outpatient department. There would be some people who will be working with the social services and zakat and betul mal people, because that's one major funding component of the medicines for the in the public sector. There would be some working in the OTs or on some in the decentralized pharmacies. So you have your team scattered at different places, and they are already having a big chunk of work with them. So when you are doing your TPN and aseptic dispensing, this work started with the volunteers. For months, rather a year, it was the volunteer force who kept with me, and they worked with me for delivering their services. And I had to work many hours beyond my regular time. The hospital used to go off at 2, but I had to start my work after doing the routine things which the pharmacists do in the hospital, meetings and many other things, and start this TPN and aseptic dispensing at 2 and finish off at 6. So who was there with me, working with me? My support staff and my volunteers. And then soon hospital realized that this is an essential service and we need to have a permanent staff for it. So they hired them. But initially we had to do this as well, that we have to totally rely on the volunteers. And I was telling you that all those people, all my pharmacist team, which were scattered in different areas and doing different works, and they were not actually the part of the TPN and aseptic dispensing services, whenever there was a crisis, because I have trained them all, they know how to do the work. I would call them, today I need your support. Not even once anybody refused. They were always standing with me, because we all knew we were there to help the patient out. And it's our collective responsibility. And today, we are seeing in Pakistan a culture in our institutions that youngsters want to become clinical pharmacists. There are positions in public and private sector where clinical pharmacy and pharmacy services are actually established, and they are ready to accommodate pharmacists. So, but developing your team, respecting your team, equipping them, giving them knowledge, training them to work independently and think independently is very important. So that I say it again and again, we are not here to produce followers. We are here to produce leaders. We need leaders who can take the responsibility, who can take the charge, who would say, do not worry, I will manage from this time to this time, it's my responsibility, go home. So yes, it is difficult, but if you are positive, if you're respectful to your team members, and if you also give them something, if you train them, you are actually giving them something. Sometimes people do not train the whole thing to their younger staff, and this makes them redundant, and it's not an honest way of leading the team. I think so. Any other question, please?
Okay, ma'am. Someone has asked about it, that we should have a policy for use of antibiotics. Why there is no rule for reducing the use of antibiotics? Otherwise, there will be more people resistant to antibiotics.
Right, very good question. That's why I have emphasized that all of you please go and read about AWARE program or AWARE classification. AWARE classification was introduced by WHO in 2017, and it's kind of a global antibiotic policy. Before that also, WHO had been saying you must have heard this phrase, rational use of antibiotics, time and again, and also telling about antibiotic stewardship program, but nobody was doing it. So in 2017, they launched this essential medicine list for antibiotics in the format of AWARE, that this group, according to their resistance potential, means the potential to become resistant, the potential in the antibiotic to become resistant, that the organism becomes resistant to it. According to that, the molecules were classified into access group, watch group, and reserve group. So that the access group should be available and accessible, and they're basically first line antibiotics. The watch group has high resistance potential, and they are restricted number of medicines which are available for the microorganisms, which are the target organisms for these medicines. So we need to use them wisely. And they are reserved medicines for which are very good in their spectras and behaviors, but they are kind of last resort. And if we try to use them out, and the organisms become resistant to them, then ultimately we will be ending up in a scenario which will be same as before World War II, when there were no antibiotics. This is called prebiotic era. So this is horrifying. So this year with WHO and DRAP, we were successful in updating the AWARE guidelines, AWARE classification for Pakistan. Rather, we were successful in making the first AWARE classification of antibiotics for Pakistan, and we are waiting for the DRAP to and WHO to notify it, so that this is regulated and legally implemented in whole of the Pakistan. And then onward, we can assume that some training programs will be conducted, but there has to be some regulatory checks, which doesn't let a reserve medicines, for instance, like linezolid is a reserve medicines, to be sold out in a retail shop without any regulatory check. First of hand, it's not supposed to be there. It should be supposed to be there only in the institutions. But if it's there, it has to be dispensed out with some regulatory checks. So if government wants, they can implement that. So some kind of a restriction, regulation, be it there for like 5-6 molecules in the beginning, will actually change the attitude and mindset of the healthcare people, healthcare professional, and the public as well. There is something which is restriction and regulation, and it is important, and it is important for the healthcare system to survive, because antimicrobial resistance is something which we cannot cope with if it keeps on growing. So it's basically the leniency in the regulation which is not letting it work. So there shouldn't be any leniency in regulations. For instance, we see many expensive hospitals, private settings, who have large resources also, but they do not have antibiotic stewardship program. So why not the regulators impose them that if they have to charge so much, they should have these services there as well. So this is kind of a flexibility or leniency shown by the regulators, which should not be there.
Okay, ma'am. Thank you so much for giving us such a precious and valuable time. Thank you so much for your valuable insights into this
Thanks for
topic.
the invite, Beta, and it's been pleasure. And I see so many comments, and I'm delighted that more than 134 people been there and been listening to it till the end. And it's a privilege. It's an honor for me. Thank you.
Thank you so much, ma'am. Thank you so much for sparing such a valuable time with us. And thank you so much for explaining so explicitly the questions of our audience. And thank you so much, audience, for your valuable and precious time for us, for sparing such a precious time for yourself to add some pieces of knowledge into your books. I hope we are so excited for the next session. Our next session will be conducted on 25th March 2023 on hepatorenal syndrome, demonstrated by Sir Ehsan Shehzad. We will see you there. The registration link will be shared with you all via email, and the certificates of this session or the previous session, if not received by yourself, will be received to you via email within 2 weeks of the activity. And meanwhile, you can fill the feedback forms, and we will receive your feedback forms and then get back to you with your certificates. Thank you so much having with us, and thank you so much for sparing your valuable time with us. See you soon. Allah Hafiz.